Next, I'd like to introduce Dr. Ben Tharian. He's at Digestive Health Institute in St. Petersburg. He's an interventional endoscopist that does many different types of procedures. He has had training here in the UK. He spent some time in Australia, and now he's in the US, so he understands healthcare dynamics around the world. Ben.
Thank you. Thanks so much. Thanks everyone for coming to this meeting, and thanks for this invitation. Right, so how I am different from these guys are all researchers and clinicians. I'm a pure clinician. So I do a lot of clinical work, and as I was mentioned, I am licensed here. I do have my British license still, and I'm licensed to practice in Australia and in the US. I'm an interventional endoscopist. I do a lot of stuff. But my focus today at this meeting would be to talk about what POEM is. It stands for per oral endoscopic myotomy. It's a minimally invasive technique that is essentially used to cut the muscle. All this time we were thinking about how we should avoid cutting muscle. So this is a technique that is used, where I use the device to actually cut the muscle. The principle is different and the indication is totally different. So per oral endoscopic myotomy, we create a tunnel. Just like what they do, we create a tunnel by raising a bleb, go in the submucosal plane, that means underneath the lining, and over the tunnel, over the muscle layer, I go deeper down and cut the muscle as much as I want. And then I pull out the scope, and I have endoscopic suturing devices with which I close the hole that I made. So you must be wondering why am I cutting the muscle and coming out? So there are different techniques, different indications for the POEM or the per oral endoscopic myotomy. One is the E-POEM. E means esophageal POEM, or they might call it O-POEM here in the UK. So E-POEM is done for treatment of achalasia, diffuse esophageal spasm, hypertensive lower esophageal sphincter, and spastic disorders. So achalasia is a condition. Achalasia is a condition where you have difficulty swallowing. It could be seen in young kids, or it could be seen in people who as old as 80 or 90 years old. The problem is the muscles go into spasm, and the esophageal muscle does not contract. So they present with difficulty swallowing, and all the food that they swallow gets stuck in their esophagus, and you aspirate it. Everything just spills over into the lungs, and patients might present with pneumonia. Very bad disease. I've got a young 20-year-old kid who had done a POEM on, who's back to almost normal now. So you diagnose achalasia and these esophageal dysmotility conditions by doing high-resolution manometry, by which you classify using the Chicago classification into multiple groups. These are the areas that we can treat using the POEM technology. Achalasia, 3 types of achalasia, and EGJ, that is esophago-gastrojunction outflow obstruction. So these are all disorders of the outflow tract, that means from the esophagus to the stomach. The outflow tract is obstructed, so food is not going down. And the other system is where patients have disorders of peristalsis. That peristalsis is the normal wave-like movement by which food is pushed down. So disorders of peristalsis where patients have esophageal spasm, or hypercontractile esophagus, where the esophagus goes into spasm and you have severe chest pain and patients present to the emergency department thinking that they're having a heart attack and they're not able to swallow anything. The moment they eat something, the esophagus goes into spasm. So very uncomfortable disease that doesn't have many other treatments, options. So this is just, I don't have many slides, I'll make it very quick. So here we are actually cutting the muscle, as you can see. You're using the speedboat device to cut the muscle, and that's the inner circular layer of the esophageal muscle that you're seeing. So I'm in the tunnel. I go underneath the lining, and I'm cutting the esophageal muscle deeper, and you go deeper, then you go into professor's territory, into the lungs. We don't want to go there. So we stop short of the muscle. So as soon as the muscle is cut, we stop. We can easily see that we've reached the mediastinum. So the clinical evidence, the evidence of the efficacy, there are several publications from Kashab in Johns Hopkins and others here, which have shown that the efficacy of POEM for achalasia is the order of 97 to 98%, compared to the previous traditional treatment, which is called Heller's cardiomyotomy, which is a surgical procedure, an open surgical procedure or laparoscopic procedure. The other condition which I mentioned, where patients have severe chest pain, jackhammer esophagus, the success rate is about 75%. So I've done several of them. Patients actually have significant improvement with that, and they're able to go home within 24 to 48 hours. So how does this compare the POEM versus the surgical approach, the Heller's cardiomyotomy? You can see that the success rate, the clinical success is comparable between the POEM and Heller's, slightly more success with the POEM procedures. Hospitalization, although it is shown in the study that average hospitalization is 1 to 2 days versus 3 to 4 days for Heller's cardiomyotomy. We have been sending patients home the same day. About almost my last 30 or 40 patients who have undergone POEM procedures, we send them home the same day because we are able to suture the mucosal defect that we made, and we are able to say that there is no leak, and the patients are able to go home with no medication, just some antibiotics. Post-operative pain with this POEM technology is minimal because there is no external incision. As they said, this is all internal, all mucosal incision, and with this technology there is no heat dispersion, so the complications are very minimal. So patients are able to go home on Tylenol or paracetamol. So very minimal pain medicines and antibiotics. The recovery is pretty good. Patients go back to work within a week and almost back to normal. There is a slightly higher risk of reflux compared to surgery, but the vast majority of this, less than 10% of this, will need some medications. And even a smaller percentage of them might need some surgical treatment to fix the reflux. And we can do it endoscopically. I do endoscopic fundoplication, by which we can actually fix the reflux as well if we do need it. And it's been shown that for type 3 achalasia, which is one of the classifications I showed you, the POEM technology is much superior compared to the surgical option. And this is the recommendation, the latest recommendation from the ASGE and the AGA, which have shown that for type 3 achalasia, POEM is preferred compared to the surgery, whereas for type 1 and type 2 achalasia, either of those treatment options could be used as first line. Now, I just mentioned to you about the esophageal POEM or the EPOEM. There are other POEM technologies as well. POEM can be done in the zengas, in the neck. So patients might complain of difficulty swallowing with aspiration pneumonias because they have a small pocket behind the esophagus where when they swallow, the food goes into the pocket rather than going into the stomach. So you can do endoscopic Senger's diverticulotomy using the same device with a speedboat, and patients are able to go home the same day and are able to swallow food the same day. The other technology, other situation where you can use the POEM technology is in the stomach. Patients with a bad disease called gastroparesis, where the stomach is not emptying, the stomach muscles are sort of paralyzed. You're able to cut the stomach muscle at the pylorus, which is the gate or the sphincter at the opening of the stomach into the small bowel. You're able to cut that muscle open to release the sphincter so that patients are able to swallow food and are able to digest it rather than the food just staying in the stomach. So there are different indications for the POEM technology. Now, the reimbursement. I work in the US, so reimbursement is extremely important. So no hospital is going to support you if procedures are not paid for. So until 2022, we did not have a CPT code. CPT code is the reimbursement code that is needed to get insurance to pay for it. So since 2022, we had a CPT code, and there's been an increase in demand for people to learn the POEM technology, POEM technique, and there's been an increase in the use of the devices as well. And you can see that the reimbursement has gone up by about 60% since 2024. And more and more physicians are trying to learn this. I've been using the device since 2018. Why is the speedboat technology superior for you doing a POEM procedure? So this is a bleb, and that's a tunnel, and that's where you cut the muscle completely. So it's safer and easier to learn, as Rosen has explained to you earlier. It's got a protective stainless steel hull that prevents the deep injury if you need to protect the muscle. That's critical for ESD and even for the POEM. You don't want to cut the muscle wherever by mistake. You want to cut the muscle intentionally. So the stainless steel hull actually protects the underlying muscle. Then the pain, due to the advanced energy and the technique that's used with the microwave, the pain that you get from the procedure, from cutting the muscle, is very minimal. That's why I'm able to send the patients home the same day. US health system definitely likes to send the patients home the same day. Every extra day in the hospital, you're given say you're given X amount of dollars for a procedure, and every single day you stay in the hospital is going to come out of that X dollars. So if you're able to send the patient home the same day, hospitals love it. So with the CPT code, so patients love it. Of course the patients love it, because patients are very stable. I've never had any patient coming back. Patients call me with chest pain. If they have any problems, they call me because I give my number to them, because I want them to feel comfortable that they have support. The other benefit is less device exchange, because this single device is able to do the cutting and the coagulation. Whereas when I used to do the previous device, I trained with a device from another company. When I started doing the procedures, we have to use multiple devices. So hospitals don't like it. In the US, definitely the hospitals don't like it, because every device is going to come out of the same X amount of dollars that being paid for the procedure. So less device exchange means the procedure is going to be quicker and faster and going to be cheaper. Because of the precision in cutting the muscle layers and preserving the muscle layers, there's improved outcomes. So less complications. You're not going to cut into the muscle. You're not going to cut into the lungs. It's very, very, very controlled treatment. And the localized effect, because of the way the device is manufactured, there is reduced thermal spread and less dispersion of the heat and improved safety. There's also one-to-one rotation, which is extremely important for the dissection. The advantages I have personally observed are that this enhanced safety profile prevents any heat spread, so patients are very comfortable after the procedure. Less charring, as was mentioned, because there's no sticking of the procedure, so that improves the visibility, because you need the visibility to be pretty good throughout the procedure. With the notch device that you can see here, with the notch you are able to notch onto the tissue, and that will significantly aid with the dissection. And you don't, previously we had to use multiple devices to actually hook onto the tissue and pull it back to cut. Whereas with the notch, the same device can be used, this notch part of it can be used to hook onto the muscle and cut it. And the predictable microwave hemostasis. So compared to the previous technologies, the monopolar technologies, with this, you are able to produce a uniform coagulation, uniform effect throughout the blood vessel wall, and very effective and predictable. So this study from this is a multi-center randomized controlled trial, which has basically shown that the vast majority of patients undergoing the POEM procedure using either a bipolar or monopolar technology, they were able to use just one device in 80% of patients who use the Creo technology or the speedboat, whereas 0% of the patients who underwent the same technique using the monopolar device, 0% actually use one device. That means all of them had to use multiple devices, every single one. So adding to the cost. This is a study from Roser, which was presented recently at the UGW, very recently, where she has basically shown that even with a single operator, even without an on-site mentor, she was able to produce very good results, even in the colon, which is the most riskiest area for doing a submucosal dissection. So very safe device, safe with beginners like me and with others. I train people to do this procedure. It's very safe to train, mainly because of the insulated hull and the controlled dissection. So why is US lagging behind the rest of the world in submucosal dissection and POEM? Mainly because of this lack of formal ESD training. Like, we don't go to Japan. There are some people who are able to commit and go to Japan for 6 months or a year. If that is available, yes, that is good. High medical legal scrutiny, much higher than UK. So we are always aware of this. So I used to work in the university hospital. I used to be able to do more colonic ESDs at that point. Whereas right now I am working in a private setup. So it's like a large community hospital. We have research and we do a lot. I'm the one who does a lot of interventional endoscopy there, but still there's medical legal scrutiny. So the hospitals also, when you are going to the private sector, the hospitals also look at how much money you are able to bring in. The moment you get the reimbursement, moment you get the CPT code, the price goes up. Now, my hospital loves me doing POEM procedures because those pay. Patients love it. So previously I used to get patients being referred by other gastroenterologists. for doing this procedure. Nowadays, patients in the US, they research and they find that you do this and then they come to you. So the reimbursement challenge, the long procedure duration in the US. So US would love to have more procedure output, so you do 20 colonoscopies or you do one large colonic ESD. But this is going to change the moment you get a CPT code for the ESD. Poor reimbursement, staff, again, unfamiliar staff, that is same for any procedure. Surgical dominance in the GI neoplasia. Even now, in the US, most places, if you have somebody with a colonic neoplasia, they will be sent to the colorectal surgeons. So that mentality has to change, and it's slowly changing with the help of pioneers like Creo, by educating the physicians and the community. So the U.S. market, there's a major opportunity in the U.S. in the underserved ESD POEM market. The speedboat solves the barriers limiting the adoption, as we discussed now, and Creo can be positioned as a leader in third space endoscopy, as Carlos has already mentioned. Why is speedboat a breakthrough? The bipolar radiofrequency allows us to do a precise and safe dissection. The ultra microwave gives you a reliable hemostasis, and you don't, when you're having a bleeder with the other devices, if you're having a bleeder, you have to pull it out and get the new device to stop the bleed. Whereas with this, you are able to stop the bleed then and there. So the protective hull reduces the perforation risk, unless you really want to cut the muscle, in which case you just turn the device and then cut the muscle. So you won't accidentally cut the muscle. That's why we feel confident about training even your fellows to do ESD. The notch improves the traction, and fewer exchanges means faster procedures, means more procedures. So the market opportunity, the US, we do around over 140 million endoscopic procedures in the US. Over 150 million endoscopic procedures in the US. Not all ESDs and POEMs, but that's the total number. There's a growing demand for minimally invasive procedures, both from the patients and from the hospitals, because it's value-based payment is a system that's coming to in the US. If a patient is staying in the hospital for 5 days and has got more complications and is more expensive versus a procedure that can be done in 1 hour or 1.5 hours, and the patient is able to go home the same day on minimal pain medicines, the patient and the hospital would definitely choose that. I would choose that too. The dedicated CPT code for ESD, once we have it in 2027, I think, once we have the dedicated CPT code, it will standardize the national reimbursement and it will improve the insurance consistency for gastric and colonic ESD. So they will pay more, so more people will be convinced to doing it. And I would definitely be able to convince my hospital to doing ESDs. In fact, my first ESD in my private setup was a 12 centimeter rectal polyp in a physician's mom who was 84 years old, and I think we were there. I think the patient was able to go home the same day. She wanted to go home the same day. I wanted her to stay, but she went home the same day. No problems. Absolutely no problems. So it's a very safe device, very safe technology, and it's a disease. It's a treatment. It's a technology that basically has got several applications, as was mentioned by Carlos already. So with the CPT code, it will dramatically accelerate the US adoption more than tenfold. So the economic driver, there will be lower cost, less length of stay, and attractive reimbursement. So to conclude, speedboat represents the next evolution in therapeutic endoscopy. There is no doubt. You've seen all the different possibilities. It's the only integrated radiofrequency and microwave in one device with a traction notch platform. So it's a platform, not just a technology. It combines precision, safety, and efficiency, and it's highly scalable. It's steeper, smoother, and shorter learning curve. Because it's a safe device, she's demonstrated in the poster that it's very, very easily trainable and pretty safe for the patients. It's ideal for global expansion, ideal for training centers, and for clinical adoption. The evidence strongly supports its clinical value and its future potential, as we have seen. So the growth of the third space, growth of procedures happening in the third space is imminent. Speedboat is an ideal platform, well positioned to lead, and it's a right technology and available at the right time. So make use of it.